So I'd like to now introduce Dr. Arina Garg. She's a rheumatologist and active in the South Asian community to overcome barriers and promote a healthy lifestyle. Today, she will speak on South Asian women and chronic fatigue and pain. And these are the information presented is from case studies, and she will be talking about challenges and solutions. Over to you, Arina.
Thank you, Dr. Bhandari. Can everybody hear me okay? Yes, okay. It's a pleasure to be here today. I'm just gonna try to share my screen 1 second. So I'm so glad I'm following Dr. Lear's talk because it really ties in nicely to chronic pain. So as clinicians, we identify pain as a fifth vital sign. In its acute form, it tells us if there is a noxious stimuli. It really helps us identify if there's something dangerous going on. But when it has evolved into its chronic form, it can be debilitating. WHO has declared chronic pain as a disease, and it is one of the most prevalent diseases in the world today. It does cause significant disability and causes and has enormous cost to the society. In Canada alone, there is 7.6 million people that are living with chronic pain. 900,000 are affected by fibromyalgia. Unfortunately, women are twice as likely to develop fibromyalgia. Women are also twice as likely to develop autoimmune rheumatological diseases, which is one of the risk factors for developing chronic pain. Women are also twice as likely to suffer from depression, which is another risk factor for developing chronic pain. And Dr. Lear really outlined some of the challenges in women with depression. So let me tell you a little bit about a patient that I saw a few months ago. I saw Surjeet with left knee pain, and she was sent for possible consideration for corticosteroid injection for osteoarthritis. She also had a surgical history of right knee total arthroplasty 2 years ago. On exam, she had a BMI of 30, and on musculoskeletal exam, she had very obvious findings of osteoarthritis of the left knee, but she also had this diffuse tenderness all over. Her labs were normal. Her imaging showed left knee had moderate osteoarthritis, and rest of the imaging just showed age-related degenerative changes. So before I see any patient in my practice, I get them to fill out this intake form where they have to indicate all the areas that they're having pain in. So this is what her pain chart looked like. As you can see, the pain is really not just in the knee. It's really widespread. She reported generalized musculoskeletal pain. She had chronic fatigue. She had sleep disturbances and cognitive disturbances. So what is the most effective management strategy for this patient? Is corticosteroid injection really going to help this patient? So let's understand this pain a little bit more. Traditionally, we understand pain as distinct categories. So nociceptive pain is, for example, if somebody has osteoarthritis in the knee, they have cartilage damage, they're experiencing a noxious stimuli, and that's the localized pain that they're experiencing. Similarly, with inflammatory arthritis, patients have peripheral inflammation, which is causing pain in the joints. For neuropathic pain, patients may have a CNS lesion or a peripheral lesion that's causing neuropathic pain, and they develop carpal tunnel or peripheral neuropathy. But in central pain, there is no noxious stimuli, there's no inflammation, there's no neuronal damage. These are the patients that are told it's all in their head. These are the patients that are dejected by medical professionals. These are the patients that undergo battery of tests and a lot of different imaging to really investigate what's going on with them. So what is central pain? Central pain happens because of a process called central sensitization, in which there is an amplification of neural signaling within the CNS. So basically, the spinal cord and the brain sort of turn up the volume to any sort of unpleasant stimuli. Our normal sensation of pain and touch, we have receptors that help us identify if this is painful or if this is a normal touch. In central sensitization, there is hyperalgesia, meaning even a minimal pain is perceived as severe pain. There's also allodynia, which means a normal touch may be perceived as painful. So these are the patients that tell you, even if they were to just go and hug their loved ones, they have pain. They have pain with just wearing tight clothing. Unfortunately, women, research studies have shown that women have a little bit more of amplification of their CNS. So they are more prone to have hypersensitization of pain. They're more prone to have hypersensitization of just sensory input. And in fact, in premenstrual period as well, women are more hypersensitive. So up to 40% of patients with autoimmune diseases such as rheumatoid arthritis, lupus, for example, experience central sensitization and develop chronic pain. So they have inflammatory arthritis, which we can treat, but they also have this underlying chronic pain from central sensitization. Similarly, traditionally we think of lower back pain as a localized musculoskeletal pathology, but we now know that they also develop some degree of central sensitization. Similarly, central sensitization is a very important mechanism underlying fibromyalgia and related chronic pain conditions. So now we understand that this is really not, these pain conditions are really on a spectrum rather than, are overlapping rather than just distinct entities. So there are genetic factors that predispose us to developing central sensitization and chronic pain. There have been some serotonin receptor and dopamine 4 receptors that have been identified, although no definitive genetic polymorphism has emerged. There are psychological stressors as well that have been identified that either are inciting or precipitate central sensitization. So depression, anxiety, poor sleep, poor stress response. And this is really the reason why an integrative approach to management for chronic pain is essential, so we can address all of these issues. So it is real. We know central pain is there because we've seen it on MRI, we've seen it on functional neuroimaging. Patients with fibromyalgia have decreased cortical thickness, they have diminished pain volumes, and they have increased levels of excitatory neurotransmitters. So we also know that patients with fibromyalgia have increased levels of glutamate, substance P, nerve growth factors, which facilitate pain transmission, and they have decreased levels of GABA, which inhibits pain transmission. So in a clinical practice, a patient comes in, it's a really good idea to get them to do sort of a pain map if they're coming in with pain, to really see all the areas that they have pain in. So ACR has developed this diagnostic criteria for fibromyalgia, which is really helpful. So besides looking at the widespread pain, we're also looking at other CNS manifestations such as fatigue, cognitive disturbances, sleep disturbances. And based on this, we calculate a score and we see where this patient falls on this fibromyalgia spectrum. So coming back to Surjit, this patient, as you can tell that, just a knee injection for this patient intuitively is not going to help her because she does have pain all over. So besides osteoarthritis, we really need to talk about fibromyalgia and really address the management for fibromyalgia. Which brings me to my second case. I want to talk a little bit more about management. So Priya, I saw a young patient referred to me with just pain and stiffness in bilateral hands. She had a history of an infection 2 years ago, pelvic infections, after which she started to develop all these joint pains. She had a BMI of 32. On exam, she had tenderness in all the MCPs, PIP, DIPs, no obvious swelling, but she had diffuse tenderness all over. Again, labs were normal. Her imaging was normal. She actually had extensive imaging done to really investigate what was going on with her for the last 2 years. And when she came to me, she was very anxious. She was convinced either she has an autoimmune disease, she has an infection, or she has cancer. She was basically anxious from the chronic pain that she was having. So yes, she had generalized musculoskeletal pain, she had fatigue, she had sleep disturbances, she had cognitive disturbances, and she had mood symptoms. This is what her pain chart looked like. So we can tell that this patient most likely has fibromyalgia. And so she met the criteria on the ACR diagnostic criteria. She met the criteria for fibromyalgia. I did a musculoskeletal ultrasound to make sure there was no underlying synovitis, because we know that a lot of these patients that are coming with fibromyalgia may have underlying autoimmune diseases. So that was ruled out. Again, what's the most effective management strategy for this patient? So patients with pain and fatigue, they develop disordered sensory processing, which then leads to increased stress, decreased activity, poor sleep, obesity, and maladaptive illness behavior. So we really need to have a dually focused treatment for pharmacological therapies to improve the symptoms, and also non-pharmacological therapies to address the dysfunction. Unfortunately, pharmacological therapies for chronic pain are just not very good. We had data on duloxetine to treat lower back pain and knee osteoarthritis. We also have data on pregabalin to treat fibromyalgia. However, the doses that are required are pretty high, and patients do develop a lot of side effects. And in my practice, in my experience, patients have maybe 30 to 40% improvement in pain, but there really isn't significant improvement. So what we are trying to achieve with pharmacological therapies, we can with non-pharmacological therapies. Studies have shown that non-pharmacological therapies reduce central sensitization. So one of the biggest steps, I think the first step to manage a patient with fibromyalgia is making the diagnosis of fibromyalgia and then educating them. A lot of the patients, this reduces significant amount of anxiety. This reduces, in fact, reduces pain as well. There has been research that has shown that education around fibromyalgia reduces pain and catastrophizing behavior in these patients, which really overall helps with their overall health. Exercise has also shown hypoalgesic effects. So there is data showing that this is very helpful. Cognitive behavioral therapy, again, is shown to be very helpful in these patients because there are psychological stressors that contribute to fibromyalgia and chronic pain. Yoga and Tai Chi, several years ago, they used to be under weak evidence. They have moved up now to modest evidence. So this is sort of an evolving field where we are looking more and more into these integrative approaches and learning more about them. So where does yoga and mindfulness fit in? A systemic review and meta-analysis of 7 randomized trials involving 362 patients found that meditative movement therapies, including Qigong, Tai Chi, and yoga, significantly improved fibromyalgia-related sleep disturbances, fatigue, depression, and quality of life, but not pain compared with controls. There was another randomized controlled trial that was done called Yoga of Awareness. This was the specific form of yoga that they had used in 53 fibromyalgia patients who were compared with the standard care. Patients were taught gentle poses, meditation, breathing exercises, yoga-based coping instructions, and group discussions. What they found was patients who did yoga, there was greater improvement in pain, fatigue, and mood, and pain catastrophizing acceptance and other coping strategies. So you can see in the chart that's taken from the study, patients who performed yoga, there was improvement in the pain and the fatigue. So they followed these patients up after 3 months, and what they found was these benefits had sustained, and patients who continue to do practice yoga, there was a sustained benefit, and there was more benefit if the practice was continued. So the other thing that has also come up is balneotherapy, which is listed as one of the things that have been used. It's known as Avgaha Sweda in Ayurveda. It's been around for thousands of years. It's one of the 13 types of, I guess, baths that are used. So typically what it is, they give patients oil massage, and then patients are sort of submerged in a bathtub with herbal medicines. And, this is something that's been practiced for thousands of years to treat low back pain, osteoarthritis, rheumatism, hip and pelvic pain. So if you look at the Ayurvedic literature, these are the things that they treat with balneotherapy. And now we know for fibromyalgia patients, there's upcoming research that's showing that balneotherapy is very helpful. So coming back to our patient Priya, what happened with her was we did education. Once we confirmed that she has fibromyalgia, there was significant reduction in anxiety. She went back, she went on a keto diet. She lost 30 pounds. She also did hot yoga. She came back, 3-month follow-up. There was no pain. She had no tender points. Her mood symptoms had improved. So, we know that there is definitely place for non-pharmacological treatment. And patients like Priya are kind of rare in my practice. There's not a lot of patients that go and do what they're told, but this is promising. But there are some challenges that I have identified in South Asian women. For example, with Surjeet, I had a lot of difficulty convincing her to do CBT. There was definitely, lack of exercise, and in fact, she was noted to be obese, but there wasn't any significant effort on diet or weight loss. So these are some of the challenges that I actually see a lot in patients that I see with the South Asian women. So future directions, again, I think Dr. Lear had also alluded to this. Challenges with CBT in South Asian population are there, and to determine if there are synergistic effects of yoga and other management strategies, improve study designs for yoga, types of practice, and which subgroups of fibromyalgia patients will respond best, and role of balneal therapy. Maybe we need to look to Ayurveda and get more information from them. Thank you.
Thank you so much, Dr. Arina Garg. That's amazing, and I was totally intrigued at such an impactful presentation, and certainly well aligned with with the work of SINS and that integrative thinking to integrative medicine. Great to see it happening in your practice. We do have a couple of questions. We're getting tight on time, but we have a couple of questions, so I'm going to squeeze them in here. Because patients are low in GABA, would it be reasonable to supplement? And there's another question also that I received. Are there natural diet or supplements that people can potentially use as well?
I'm sorry, do you mind repeating the first question? I missed that.
Because patients are low in GABA, would it be reasonable to supplement?
Unfortunately, I'm not very familiar with the GABA supplementation. I'll have to look into that, yeah.
Just in general, are there any supplements? And you're looking at you talked a little bit in the end about Ayurvedic medicine. Are there any types of supplements or things like that that you've used with your patients that you have found to be successful?
Yeah, so vitamin D, actually, there was a study that came out of UK, which I didn't get a chance to include in them. They found that, in fact, they hypothesized that South Asian women had low vitamin D levels and they tend to have more chronic or widespread pain. So they found there was an association with low vitamin D and widespread pain. So in my practice, I see that. I always check all the patients with fibromyalgia coming in for vitamin D levels, and most of them do have low vitamin D levels. So we supplement vitamin D. I don't know how much difference it makes, but this is definitely, something that is being looked at in research.
So Dr. Garg is thinking there. Minnie is going to mention the vitamin D. He knows I have my vitamin D soapbox. You prescribing, ordering vitamin D for your patients is actually covered for them. But unfortunately in British Columbia, if a family doctor orders a vitamin D, it has to be paid for.
Yeah.
So there's still some barriers even there. Now the questions are all coming in and they're scrolling through quickly. Could you make your slides available? So would you be okay with making your slides available? So
yeah, absolutely. Yeah, I can email that. Yeah, not an issue.
As well, all of our presentations will be posted onto the SINS YouTube channel. So when we do a follow-up email with participants, you will be provided the link where you can go and look at the presentations as well. Yeah, it's a wonderful presentation. So I'm sure we could talk on this for a long time, Arina, but due to time, we have to move